use. And one of the most common areas to have arthritis in that age group is at the base of the thumb. And I'll use my models again to show that. So base of the thumb arthritis is very common, and it would be in this location right here. And this used to be one of those conditions where patients would hear, well, you're just getting old, you're going to have to live with the problem. Well, think about it. Part of what makes us human is language and having an opposable thumb. So having a painless thumb is very, very important for human activity. So that's not really a great answer to tell patients. And the standard operations when the pain was severe was a fairly large incision, generally from here all the way to here, removing this bone from the body. The arthritic bone would actually be carved out of the body. And then a tendon like this would be harvested, and we'd make drill holes in the surrounding bones and weave that tendon through to stabilize the thumb. That's quite a bit of surgery and a lot of recovery for the patient. Now,
especially the 50 to 70.
Yes, exactly. You know, you're talking about 1 to 2 months in a postoperative cast or splint, and certainly 3 to 6 months of recovery was common. So over the last several years, I've been trying to innovate and use the same type of flexible scope techniques that we talked about with carpal tunnel for the small joint in the base of the thumb. And now with better optics and better equipment and smaller scopes, what I do is I put a little portal, which is a little incision, pass it through the skin with the scope, and then I have a view inside the joint on a big screen. And then we can mechanically put in little shavers and instruments and clean up the arthritic tissue. If the arthritis is severe enough, which it often is, then the cartilage is quite damaged. That's the smooth tissue that lines the joint. So if there's no cartilage, that joint is going to be painful and limited in motion. And now we have bioengineered materials that can be a cartilage substitute. So I'll connect those two little dots, make about a 1-inch incision only, and then place this as a shim between the two bones of the joint. And the recovery, again, with this technique compared to conventional techniques is much faster, about half the time in my patients.
So what happens, there might be bone spurs, and then you can also shave that with microincisional
Exactly.
techniques.
We have miniature little shavers, and I'm glad you brought that up because I brought with me today some video that we can go over right now. So in this first one, what we'll be looking at is doing an endoscopic carpal tunnel release. And this is an actual surgical demonstration in an operating room. And you see that there's very small incisions being used here. And then there are some markings on the skin that show where the major tendons are. And then as the tape rolls, we also see a cutaway of the surgeon's view inside the carpal tunnel space. And that's very interesting. What's most important for the audience is to see how small that incision is and actually what can be viewed through such a small incision. I brought another tape which shows the arthritis surgery, yes. And here I just wanted to show what the conventional or standard operation was. And so here is a sequence that will flash through fairly quickly. And what I'd like you to pay attention to is how many little steps are required to do this operation, with taking of the bone and then harvesting the tendon and then making these two bone tunnels in the two bones that are near the arthritic joint, and then having to weave and pass these tendons through. The operation works well, but it's quite a bit of surgery. On this next tape will just show real briefly the arthroscopic view inside this joint. And what we're seeing here is that instead of it being clear fluid, it's cloudy fluid, and there's a lot of debris. And it looks like, we say, it looks like crab meat instead of being a smooth, shiny surface. And mechanically, that metal thing is debriding the joint and actually shaving and smoothing down this damaged cartilage.
To make it smooth.
Yes.
So then there'd be no pain on movement.
Right, to reduce the pain. And if there's not enough cartilage, as in this view, a severe case, then we have to put in the cartilage substitute, which we can easily do through a fairly small incision.
So the cartilage substitute, you've been played a major role in creating that.
Well, it's interesting. This is a technology that came from Europe, and now it isn't available in the United States. But actually, I've adapted some of my own techniques to utilize this material. And in fact, later this year in San Francisco, we have an annual meeting of our specialty society, and I will be helping to demonstrate and teach my surgical techniques using this bio-engineered material, hopefully to a wider group of surgeons. So this is more commonly available to patients around the country and, frankly, around the world.
Now, both techniques have been around for 15 years, including the arthritis surgery?
No, I'd say the arthritis surgery is within the last 5 years because every few years the optics improve on the arthroscope technique so that now the size of the scope is less than 2 millimeters, and that's about the size of the lead of the pencil, so really small. And then, of course, just like at home, we have plasma screens in the operating room. This is HD technology, so the view is quite amazing. And it's actually a better view than if you open up the joint and look with the naked eye. The view with the scope is vastly superior. So it actually allows us to be better surgeons because we're seeing more detail of the arthritic joint.
Now, to sum up for our home audience, we have a few minutes remaining. If you have unrelenting pain that's lasted for more than just a few weeks and pain or tingling down to the fingertips, go see a hand surgeon, a person who is certified in hand surgery, not just your family practice doctor, because you need somebody more specialized.
Well, you bring up a good point. And again, in an era where we're trying to figure out who is the right person to do the care, and a lot of emphasis on primary care, I would say that not all of my primary care colleagues are so expert in making these diagnoses. As a surgeon, we understand some very minute things about the anatomy, details of things like bone spurs and the nerve conduction test. So I do think that it's a really good idea to see a hand surgery specialist to help make the diagnosis, even if you're not wanting to have an operation right at the first visit. I think it's very helpful to make sure that you know what the problem is, and then you can start the simple treatments first.
Well, thank you so much for joining us. This has been a great topic and very interesting to me and to everybody at home in the audience because we all use our hands, and I hope you come back and join us again.
Oh, it'll be my pleasure. Thank you, Gloria.
Thank you.